Hello, ladies and gentlemen. Welcome to HAS 20 Virtual Summit Breakouts. During this session, you'll be able to submit questions and upvote questions from other attendees. The questions with the most votes will most likely be among the questions asked by the host to the presenter at the end of the session during the live Q&A. The bottom right tile box is where you can type in your question as well as click the thumbs up button to upvote a question. During the session on the top right tile box, you will also see a 5-question quiz based on the speaker's content. Enhance your learning by taking the quiz during the session and get points for your correct answers. All sessions will be available on demand, and if the presenter has given us permission, you will also be able to download the slides. It is now my pleasure to introduce session 32, Prioritizing the Patient in Value-Based Care, a data-informed approach. It will be presented by Tyler Gauthier, Director, Value-Based Care, OneCare Vermont, along with Katie Muir, Supervisor of Population Health Analytics, OneCare Vermont. Enjoy the session.
Hi, thank you for joining our session today. Katie and I are here from OneCare Vermont, which is an accountable care organization that serves the entire state of Vermont. Today, we're going to talk to you about the way that our ACO is prioritizing the patient in value-based care, and really how we're using data to drive outreach and inform patients to bring into the interventions that are happening across our state. Here's the agenda that we're hoping to cover with you today, assuming that folks have had a chance to take a look at the agenda and that you're familiar with the session description because you made the decision to come join us today, and we're thankful for that. I do want to spend some time covering the learning objectives, making sure that we clearly articulate the things that we want to share and the things that we want you to leave with today. So first, we're going to give you some background information about OneCare Vermont, the ACO, what makes us unique, and how we're improving communication across the state to support these population health investments. Next, we're going to go into additional details about all of the data that are going in and coming out of our statewide care model and how it's really supported by a data and analytics team behind the scenes. You often don't picture a team of data and analysts supporting a clinical program, but this model and the presentation today is going to cover the ways that our analytics team is supporting this population health investment. Next, we're going to talk to you about our data literacy initiatives and the way that we're supporting our statewide network and creating the collaboration framework, which we believe is going to result in improved performance for our participants. Next, we're going to describe the methods that we're using to evaluate the impact of change on a defined outcome. And for the purposes of today, we're really going to focus on that care coordination program, share with you the process metrics that we're using to track change over time, and how we're using outcome metrics to create our return on investment statement and show from a data and analytics standpoint what this program means on cost and utilization metrics that are tracked by the ACO. And then last, we're going to share with you the way that we've responded to the public health emergency and how OneCare is using data to identify patients that are most vulnerable to becoming seriously ill or even losing their life from COVID-19, and how we're supporting our network to identify those patients. All right, so as promised, we want to tell you a little bit about the OneCare Network. The OneCare Network is a statewide network of providers and organizations that voluntarily decide that they want to participate in an ACO. I also can't tell you how many times I've been asked what state Vermont is in. So right off the bat, for anybody that doesn't know, Vermont is a state up in the northeast corner of the United States. We do serve the entire state. And for geographic explanation, to show you kind of the distance that it takes us to get from one corner to the other, I'll point out that if you start at the top left corner of the state and you look at St. Albans, that's the hospital up there, and you look all the way down to the bottom right corner and you see Brattleboro, Vermont, it takes me less than 3 hours to drive from one corner of the state to the other. That's important for us as we think about providing technical assistance and support to our ACO network, being available and having a presence in the community so they know not only about the programs that they're participating in, but they have the representatives from the organization able to be out in the communities to support conversations, to host town hall style meetings, and to really work boots on the ground to drive this change. The state of Vermont has a population of just over 630,000. As we think about attribution to the ACO, and we think about making that transition from fee-for-service to value-based care and needing to have a majority of the patients receiving that fixed payment in order for the hospitals to start to feel like they can back up on some of the priorities and shift in some new directions. It's important to point out that about 87% of Vermonters are eligible to be a part of the ACO or to be a part of these value-based contracts. And that's really based on insurance. So for example, if a patient is uninsured, they wouldn't be a part of the ACO. Other example might be if the patient's on TRICARE, they wouldn't be a part of the ACO. It's also dependent on their payer. And so you'll see here, we're sharing details of what programs we're running in 2020. And that's Medicare, Medicaid, and a couple of commercial payers. We have 14 hospitals across the state. Each of them are participating in the ACO in various levels, meaning some may be in one program and not the other. Over 130 primary care practices. The composition of our network is very diverse. We have nearly 300 specialty care practices. The number of FQHCs is up to 9 in 2020. A bunch of skilled nursing facilities, 10 home health agencies, 11 designated agencies for mental health and substance abuse, 5 local area agencies on aging. As Katie talks a little bit later about the composition and participation of our statewide complex care coordination program, I'll just preface this and say, take note of the composition of the network and realize as she's speaking that all of these organizations are participating in our statewide model. All of these organizations have data that's special, unique, and really important to us to think about as an ACO and how we advance our programs. Again, sticking with OneCare Vermont as the accountable care organization, people often ask us, what makes an ACO successful? Other than the obvious, most people automatically assume that in order for an ACO to be successful, they need to generate millions of dollars of shared savings. Well, that really is important to us. It's also worth pointing out that any shared savings that we have as an ACO is sent back out to our hospital network. So starting with the most obvious way, we really use the framework of the quadruple aim to measure the effectiveness of our ACO over time. Starting at the very top of the quadruple aim, if we think about our opportunity or ability to stabilize costs, I previously shared with you that we now have almost or just over 50% of Vermonters who are eligible to be a part of these value-based contracts in and being a part of the ACO. As we continue to increase our attribution and we scale to other providers within our state and move those providers away from traditional fee-for-service and into these fixed payments or value-based contracts, we believe that we can not only stabilize the cost, but by also deploying additional population health investments and strategies and providing all of the data needs, we think we can ultimately drive down the cost. And Katie's going to tell us more about some of the metrics that we're tracking that help us to tell our story as an ACO. Next, we can't thank our provider network enough. This is a voluntary network that comes together because they're invested in the success of the ACO. They care about their patients. They want to share data. They want to work collaboratively. In a state like Vermont, patients don't stay inside the boundaries of their community or their health service area. Vermont is a rural state. Patients may see somebody in one corner of the state and also in the other corner of the state for a different reason. And so we are trying to provide as much value to this provider network, really to support them and to improve their experience, and also to sort of push that onto the patient and ensure that the patient is feeling the benefit of being a part of this community that has come together because they're truly invested in making sure that the patient's experience is better, that they're closing those gaps in care, that they're treating those chronic conditions as best as possible in the best setting for the patient. So that really hits on the fact, we need to drive quality, we need to continue to improve care. And we're working very collaboratively with our patient and family advisory committee, including them in conversations using the patient and family advisory committees that exist from across our statewide network and each of the organizations that's participating, and making sure what we design is truly meeting the needs of providers and patients, and in turn, helping us to show that we can drive down those costs and that we can improve the care that patients are experiencing. So there are many ways and many different interventions that OneCare Vermont is supporting across the state. Here on the slide are an example of just a few. In today's presentation, we're going to largely focus on our flagship investment, which is the financial investment that goes into the statewide complex care coordination program. It's important to point out that as an ACO, one of the things that makes us really unique at OneCare Vermont is we have no internal staff that's providing this complex care coordination to patients. We have no team of nurses or social workers that are picking up the phone or working directly with patients. Instead, we're supporting this from an investment standpoint, and we're really pushing a lot of data into this program that Katie will cover. And on the same token, we're really relying on the data that's coming out of this program in order for us to continue to tell our story as an ACO, to have conversations with our payer partners and with the regulators in the state of Vermont to really show the value of this community-based program. And as I talk to you a little bit about the composition of our network, it's also important to think back and realize that this investment is really being deployed to those organizations. So the money is going out to primary care, home health, the designated agencies, the area agencies on aging, and even some congregate housing sites in some cases. But there are expectations of this program. There are technical definitions that we'll go deeper into. There are metrics that we're tracking. And this is just one, but for the purpose of today, we really want to focus our presentation on the data that we use to prioritize patients in value-based care. Well known and undisputable that uncoordinated care is expensive care. That means that patients are seeking care from different providers. The providers may be ordering tests multiple times. Patients are not receiving high quality care and are having to sort of escalate into different settings. If you think about this in the most simple ways, many of the chronic conditions that patients experience can be treated in primary care. We can prevent some of that escalation and utilization, meaning moving patients into the ED or into inpatient settings, by better coordinating the care that they receive in the most cost-effective location. And so without further ado, I'm going to move us forward and I'm going to turn it over to my colleague, Katie, and she's going to go a little bit deeper into some of the concepts that we've talked about so far. So Katie, take it away.
Thanks, Tyler. Hi, everyone. I'm going to be talking in a little more detail about our care coordination population health investment and how we use data to support and move that model forward to achieve some of the goals of the quadruple aim. And also how my team of population health experts and analysts are able to create tools, build out metrics, design evaluation frameworks to measure impact, and provide data literacy support across the network to really help us be data-driven in our approach to value-based care. So Tyler mentioned all the organizations that are part of the ACO, 178 organizations total. These organizations all have access to different data, use different systems to track their interventions, different EMR systems, and they also may not have technical or data supports in-house for many of them. So OneCare is really able to provide that centralized tool, unified tool that everyone can use, and provide access to centralized data to get all the organizations working together towards the same goals that they can all be measuring in the same way. We do this in a few ways. We start by using data to align members with a health service area based on their alignment with a primary care provider. We also summarize data from our many data sources that I'll go into more detail on in a little bit to create patient profiles that we're able to load into that tool. And also we are able to calculate predictive risk scores that also help prioritize engagement with the patients most likely to benefit from the intervention. So all the organizations across the state have access to these profiles and risk scores in the same tool and can record engagement with their patients in the same place. Because of this coordination of data, a new care coordinator engaging with a patient through this tool can quickly see their medical background, their predicted risk, if they have a shared care plan, or if they're already working with any other care team members across the state. So that's really beneficial to that workflow. As an ACO, we have access to a lot of data about our attributed members. So the core of our data is claims. We can understand utilization patterns, chronic conditions, and complexity of care from that claims data. And we also use that data to run through our algorithms for predicted risk scores and to create other prediction and prioritization elements that people can use. We also have a statewide clinical data feed that gives us access to some more real-time data around admissions, discharges, and transfers, as well as lab feeds that help us to understand how well certain conditions are being managed and also help us to comment on quality of care being provided. We have basic demographic information we can use for some population health assessments. And we're starting to work a lot on getting more social determinants data. We have a couple different ways that we're doing that. We have a new effort with our Agency of Human Services at the state level to try to get some more of the data that they have available about social risk. And we currently have a preliminary risk score that we're able to feed into our tool so that people can really use a risk score based on social risk and the risk score based on medical risk in conjunction to make those decisions about how they want to prioritize their panel. Additionally, the care coordination tool itself becomes a data source. There's so much information that's being entered into that tool about interventions, how people are tracking engagement, and we're able to take that in and make it available to people so they can really understand how they're engaging with their network. And I'll talk about that a little bit more in a bit. So this risk stratification and prioritization, all based on data, really is the underpinning of our population health approach. So in this visualization, you can see the 4 risk levels that we create based on those risk scores: low risk, medium risk, high risk, and very high risk. And there's recommendations for engagement under the model based on these predicted risk levels for each year. The high and very high risk, so the bottom 2 squares there, are really where we're focusing the engagement. You can see that these people make up 16% of the population, but they account for 60% of spending, 95% have multiple chronic conditions, and 52% have mental health comorbidities. So the data is really driving the focus to these populations that can most benefit from the care coordination intervention. So those prioritized patients become the center of this person-centered community-based model. So you can see in this visual, those patients right at the center, surrounded by their care team, the core of really any care coordination program. But surrounding that care team is a lot of robust data and support that's coming from the ACO. So we have self-service tools that can allow providers to get insight into their patient panels, like I already mentioned. We have monthly standard reports that provide a really high-level look at the progress under the model. And all providers also have access to our analytics team through the Data Literacy Initiative, which I'll talk a little bit more about in a second. They can request specific reports to track their work or work directly with one of our population health analysts if they aren't sure what they want to look at from a data perspective. The data generated within the tool is also fed back to them in a self-service tool so they can really engage with their panel in a data-driven way. We've built out metrics, goals, and benchmarks that are all based on data that we can gather through the tool to really support this model. So this really allows care teams and participating organizations across the whole state to be working towards the same goals and really tracking and understanding engagement in the same way. It's also the underpinning of the payment model that we mentioned earlier. The targets and goals are set based on risk stratification and some clinical judgment. And this model assumes that highest risk, 15 to 16% that I mentioned, should all be reviewed for care management, and that about 15% of those will engage and benefit from care management. So those goals are all set within the tools as benchmarks for the organizations. Within the tools, providers can indicate when a patient has initially engaged in care management, any initial engagement activities, and then when they've become fully engaged, meaning they have a lead and a completed shared care plan. We call this fully engaged status care managed, and the care managed status releases payment, and it also is the anchor date for any assessments that we are doing on the impact of the intervention. So I'll talk a little bit more about how we measure that impact on this next slide. So for our initial evaluation, we're using a pre-post methodology. So that means that we're really looking at that care managed date as the anchor date, and we're looking at the 12 months before and the 6 to 12 months after that engagement to see if we can see any differences in our key performance indicators. The main indicators that we're focused on right now are per member per month spend, ED utilization rates per thousand per year, inpatient admissions per thousand per year, and primary care engagement. We're still in the early stages of having large enough cohorts to be able to see really consistent outcomes from this work. But you can see on this slide that we are looking at our Medicare population ED utilization rate at a snapshot in time. And we do see a reduction, an indication of a reduction in this population. We have seen at certain points in time in the cohort up to 33% decreases, but it's so dependent on the cohort at this time because of sample size. But we have over 4,000 patients across the state who are care managed. So we're really excited to continue to use this methodology to monitor that cohort over time and see if we can start to see some consistently positive results. With so much data supporting everything that we're working on, it's always been really important to us to have a really data literate network that can use all the analytics and understand how they can support their work. We started out by offering some in-person and virtual trainings across the state. We were able to travel around, as Tyler mentioned, because we're not too large. So we were really able to get to all the health service areas and really give them an introduction to our data and how it's being used. We've also made many of those trainings now available through an e-learn system so people can access them whenever they need to really support their use of the data. Additionally, this year, we took a step further to have a really concerted data literacy initiative. Through this initiative, we created readiness checklists that went out to all of our organizations, where we asked them to identify data champions and data leads within their organization. We also created a position within our team that I've mentioned a few times, our population health analyst. This analyst's role is really to make sure that data is accessible to all the organizations and be a resource within OneCare that's always available to work with them within this data literacy matrix. So you can kind of see in that visual, we've created the ability to have a data steward in all of the organizations that has a really clear bridge to access support within OneCare. We've already seen our network become more data literate. They use our tools more, and they're able to put in really thoughtful, well thought out ad hoc data requests that are supporting the work that they're doing. So we're really happy with where that's come so far, and we're going to continue to expand our data literacy efforts in the future. So with that, I'll pass it back over to Tyler to talk more about our next steps and tell you about how the care coordination model that I talked about and this cultivating of this data literate network have really made us well poised to support the response to the current pandemic.
All right. Thank you, Katie. We've shared quite a bit of details with you about the programs and the ways that we're supporting these programs from a data and analytics standpoint. And really, we've just scratched the surface. There's so much more exciting work that's happening across our statewide organization that we look forward to sharing in the future. I'm going to transition and tell you a little bit about what we see as the strengths, the opportunities of our programs, and share with you where we're going to go next. So starting with the strength, I'll say that we remain committed to our programs. What I mean by that is we're thoughtful up front. Before we deploy a program, we need to ensure that we can sustain that program year over year so that it can be scaled across our network, and really be careful that we're not standing programs up that don't have sustainable funding or buy-in from our network that they want to continue to participate in. So we've seen a lot of comfort and success by having that thoughtful process and having those collaborative cross-organizational connections to share this before we deploy anything. Next, as an ACO, we feel that it's very important that we work with communities to create goals that are important to them, goals that they think that they can achieve, and that we're using those boots on the ground experts who know their organizations and know their communities better than we can in a central location. And working collaboratively with them, we're able to help them to identify some of those goals and support insights through the tools and the applications that we're deploying out across the network. Next, I think it's important to point out that we really benefit by bringing together a very diverse network. We've shared some details, we've explained to you the composition of our network, but the expertise and the value that comes from having such a diverse network is critical to our success. And through our clinical and governance committees, we glean so much knowledge and information from those participants. And then last but not least, we're so thankful that we've been able to deploy this statewide communication tool to support this care coordination program. This tool is not only a tool that we push a lot of data to so that folks that are working elbow to elbow with patients have access to that information, but it's also such a rich data source for us to pull back information and determine how we're doing in these programs. It's agnostic of EHRs, read-write access is equal for everyone. So that system is something that wasn't off the shelf for us. We've designed and built it, and we continue to evolve it to meet our needs. All right. So, well, we've had a lot of strengths and success as an ACO, a young ACO, or a young organization. There are many things that are opportunities for us and where we want to focus time. And so I'll start by saying that while we celebrate the fact that our network is diverse, we also realize that each of these organizations that's come together to participate is serving a different population. They're speaking differently. What I mean by that is a primary care practice that's a part of the ACO is working and serving a different population than maybe home health or a skilled nursing facility. There are times where there's overlap, and that's where we really need to remove the barriers so that these continuum of care partners can come together, align on a population that they're going to serve, and ensure that we're working collectively as a team and focusing on the quadruple aim so that we can see our success as an ACO. We're also really well aware that there are funding discrepancies and disparities between the continuum of care partners. Home health is funded differently than primary care. Specialty is funded differently than the designated agencies. And so as we deploy these programs, we're very careful to ensure that we're providing the financial resources to create the expertise within these organizations to serve our patients and to help us make improvements in the areas that are critical to the success of an ACO. And then last but not least, we remain extremely interested and curious about different sources of data. For example, we're working hard through a grant with the Center for Healthcare Strategy with funding from the Robert Wood Johnson Foundation to work across our state and identify those pockets or those data sets that are going to help us to look right alongside medical complexity and start to identify a patient's social complexity, which is equally as important to us. And making that information available in our tools and our apps will help these care teams to better serve the patients. And so moving on to where we're going to go next, there are many places that we're going to go next, but I'll share with you just a couple of the areas that Katie and I are hoping to move our organization. So we've talked about care coordination. Katie shared with us the evaluation framework that we're using to measure the effectiveness of that intervention. We want to begin to study this data and to identify the patients upfront that are most benefiting from the interventions that we're deploying. That's helpful because we can then use that information to go out and bring in additional patients that would benefit into these programs rather than having to wait for somebody to go out and find them. We can make that information available. They can receive the intervention sooner, and then we can start to address some of those cost and utilization metrics. Next, we've put a significant amount of effort into our data literacy initiatives. We're working to continue to improve that. We want to make sure that as we think about clinical teams coming together and not all of our organizations having these robust data and analytics teams, that we are that resource, we are able to help them. We can create the best, most high-tech, most useful tools in the entire world. But if we don't train our network how to use them, if we don't educate them on what the purpose of these tools are, and we don't include them in the design and deployment, we're not going to see the adoption that we're hoping for. On the same token, as we think about our patient-centered care model, we want to move our evaluation and our metrics away from things that are just looking at cost and utilization. So while that remains very important, that we can show that we're preventing emergency department utilization, that we're preventing admissions and the corresponding readmissions, we also want to think holistically about the patient and be able to develop metrics that show that a patient's life has changed or become better because of this interaction. We also want to think about the ways that families are being served by this statewide model. And then last but not least, we are so committed to improving and building out the way that we can make data available to our network. In many cases, we see ourselves as recipients of this data. We, in some ways, are being lent this data, and we have to operate within the constraints of our data use agreements. So the more that we can create the policies that make our data transparent and available, the more that those data are going to help to advance our strategic initiatives as an organization and ultimately where we're going to see the most change. So we've shared with you where we intend to go next. And next, we want to just cover some of the results that we've seen in our program through 2019 and really focus on these wins, because this is what keeps the wind in our sails and keeps our team so motivated to push this work forward. First, we want to address the fact that in our Medicare cohort of patients that are receiving the intervention of care coordination, we're continuing to see an uptick in the number of those patients that are actively connected to their primary care teams. That's critically important for us as an ACO because as we work to deploy these programs, we want to be able to keep patients continuously attributed to the ACO so that we can see year over year the impact of these investments in initiatives, clinical initiatives. So of our patients in that cohort, 96% of them engage with primary care. Very, very important to us. Next, Katie shared with you our evaluation methodologies and the way that we look at the cohorts in our programs and determine if these programs are resulting in positive changes. The cohorts change frequently, so I'll share with you that at a point in the year, we saw a reduction in emergency department utilization as high as 33%. That shifts and changes a bit based on who's in the cohort and for how long they've been in the cohort, but that gives us positive affirmation that these programs are starting to work and we're seeing some of those reductions that we would hope. And as we bring additional people into the program, we're hoping that these results can be scaled even further. Next, moving from 2018 and into 2019, we started to redesign some of the components of the program, the care coordination program, from a technical definition standpoint and an underlying payment model structure. Our network came together to make some changes and advance those changes up through OneCare's board of managers, who ultimately endorsed those changes. And through that process, we saw a very impressive, actually 9-fold increase in the number of patients that were in the care coordination program and receiving that intervention. Not only is that great to see more patients have those care teams and that they're working towards goals, but also it brings additional data into our evaluation framework and it helps us to see what change can look like on a bigger scale. And then last but certainly not least, we're very proud of the fact that in 2019, we provided data literacy training in all 14 of our health service areas, oftentimes more than once. Obviously, coming into 2020, we were kind of quickly stopped by this pandemic, and that's fine, but we're very anxious to continue to support our network. Some of the ways that we're doing this now are by being available on Zoom calls, by deploying a lot of the education to our eLearn platform so folks can access our data literacy training at a time that's convenient to them. We've started to think differently about the way that we train our network to use tools and apps. Sometimes in the past, we would do face-to-face or group sessions. And obviously, because of what the whole world is going through, we've had to think differently. But we've continued to see a lot of success. And we're very proud of the fact that we've been able to support our network in an impressive way. So with that being said, I'm going to pivot a little bit and talk to you and share some of the details about the way that we've shifted focus and started to think about how we can respond to the pandemic, again, through the same lens of prioritizing the patient. And so we actually really benefited from the fact that we've taken on a great deal of work to prioritize patients in the care coordination model using those cost and utilization metrics and other data that Katie mentioned, like risk stratification. We were well suited to respond to those criteria that were being advanced by the Centers for Disease Control, the World Health Organization, and Johns Hopkins, and be able to layer into our tools a way for providers to look at their panel of patients and see who may be meeting some of those risk criteria or vulnerability criteria. So I'll share a little bit more information about this new self-service application. Here's a snapshot of what the tool looks like. It's visually built like many of our other apps. You'll see as of the time that this tool was deployed, we had just under 200,000 lives in the program, in the programs that had contracts signed at that point. Essentially, what I want to show you here is that number might seem very overwhelming. Vertically, you see that the risk criteria is just above that. And so as you begin to select those risk criteria, you can see that number changes quite a bit. At the same time, we've continued to evolve this application based on the criteria that are coming out of those reputable international organizations. For example, you'll see on the bottom left of this screen that we've brought in a connection to our state health information exchange, and we can expose results of COVID-19 testing. What's blacked out below is actually PHI. So it shows you all of those details from that statewide communication tool that Katie shared with you that's supporting our care teams. Shows you who might be on the care team, who might be their lead care coordinator, as well as if you were doing some scrolling, you would see some utilization patterns. So for example, emergency department use, total cost of care year to date, and some others. So as we think about our full population being just over 180,000 or nearly 190,000 lives, That's overwhelming. And so as we look at the criteria that are being advanced, you can see those are exposed here. And we start to select those criteria, and the list of patients who are meeting those criteria starts to whittle down pretty quickly. So by selecting those top 4 risk criteria, which are really focused on, the top 4 are focused on age with corresponding chronic conditions. They're focused on patients who are considered frail, again, based on the conditions, focused on patients who have been historically identified as being high healthcare resource utilizers. What we mean there is that we look at utilization in bands. If this filter is selected in the app, we're looking at really the top 2 highest resource utilization bands. And then the 4th one that you see there are patients who have seen at least 7 different providers in the past year, which at baseline would indicate a potential coordination issue. And then you add a pandemic on top of that, and it exacerbates an already likely problem that's likely occurring. So again, taking our population from just under 190,000, applying these risk criteria from those organizations I mentioned, our population at risk goes down to just under 1,700 patients. And that's across the entire state of Vermont. So if you're a user of this self-service application, you're really looking at patients that are attributed to you. This tool helps to support the identification of those that are truly most vulnerable of becoming seriously ill or even losing their life if they were to become infected with COVID-19. As we've mentioned, social complexity is very important to us as an organization, and we're working hard to further identify patients that are meeting those social complexity indicators. We've been able to bring 2 of those indicators into this application. And you can see again, across that population of just under 190,000 lives that are in this tool, there are over 4,300 lives across the state who are meeting those social complexity indicators focused on food access issues and or social isolation. Food access is really looking, using a data science model to look across the state and identify food outlets and to apply a quality score. And then we're looking again at our demographics information to map distance to food that would be of high quality, both on foot and in a vehicle. Social isolation is what you would assume. It's looking at neighborhood complexity. It's looking at access to transportation, distance to hospitals and primary care providers. Again, this is not intended to be the end-all be-all for prioritization, but it's a good place to gain some additional insight into social complexity, as many of the other criteria that you've seen have really been focused on maybe medical complexity. We also know from the recommendations of the Center for Disease Control that social complexity is another vulnerability category. And so we've continued to revamp this tool to meet the needs of our participant network. All right, so we want to leave you with some key recommendations. There are so much more that we want to share with you, but because of time, we're going to transition to these recommendations. And we hope that if you take nothing else away from what Katie and I have shared with you today, that you think about these 4 key recommendations. 1, educate and answer questions about data to help providers improve their performance. We've talked a lot today about the concept of data literacy, but based on the complexity of the data that we have available to make to our network, we are accountable and responsible to make sure that they understand how to use that data, they know what data to use to make certain decisions, and that they're not using data to answer questions that are really not helpful, or maybe even pushing them to answer questions without all of the information. Next, assess process metrics and use insights. We've talked a little bit about the process metrics that we're using, but we really want to share with you that these process metrics are so helpful to see how these programs are progressing, to see how networks are responding to different interventions that are being put out. And then from that, we can use the process metrics to craft our story. We can craft and share details with our payers and our regulators and other partners around the state of Vermont to show that we're making progress and change takes time, but we're on the right path. Next, review data as teams to share decision-making and identify and disseminate best practices. Really, some examples that come to mind for Katie and I there is we've been very considerate and careful to bring together regional parts of the state, create core teams where we're making sure that they understand that they really are in the driver's seat. They need to be making the decisions, and we can support them. We can help them to ensure that the goals that they're selecting for their communities are in line with what's happening in other parts of the state. But it's not any one person's job, and it's certainly not our job as an ACO to think that we have all of the answers. So by bringing these teams together and engaging them in the decision-making process, it creates accountability and it pushes people towards the goals that they're setting for themselves and their community. And then last, but certainly not least, increased analytics adoption among users and risk stratification across payers. And so we've, for a long time, been using a risk stratification tool that helps us as an ACO to identify patients that may be high or very high risk. But it's also important to note that that's risk of spend in the coming 12 months. It's not risk of bad outcomes or something that we don't know that's coming down the line. And so we need to continue to bring in those data sources. We need to continue to take data sources and have a process that allows us to look across our population and see, not only who would most benefit from the intervention, but also how we can bring in additional resources to support these programs based on the needs of the population being served. And that's true across all of our payer partners. So with that being said, we want to thank you for taking the time and spending the time that you did with us today. We're happy to answer your questions, and we would love to talk to you some more.